Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachijian, and today I'm joined by Dr. Greg Lehman. Greg Lehman is a physiotherapist, chiropractor, and strength and conditioning specialist treating musculoskeletal disorders within a biopsychosocial model. Prior to his clinical career, Greg was fortunate enough to receive a Natural Sciences and Engineering Research Council Master of Science Graduate Scholarship that permitted him to be one of only 2 yearly students to train with Professor Stuart McGill in his Occupational Biomechanics Laboratory, subsequently publishing more than 20 peer-reviewed papers in the manual therapy and exercise biomechanics field. Greg was an assistant professor at the Canadian Memorial Chiropractic College, teaching a graduate-level course in Spine Biomechanics and Instrumentation, as well as conducting more than 20 research experiments while supervising more than 50 students. He has lectured on a number of topics on reconciling treatment biomechanics with pain science, running injuries, golf biomechanics, occupational low back injuries, and therapeutic neuroscience. I've been following Greg's work on social media for some time now, and I've always appreciated the non-binary way in which he analyzes issues in his field that are often unnecessarily divisive. His work focuses on reconciling different ideological lenses through which medical providers look at pain. As you'll see, Greg does a remarkable job depicting the complexity of pain and other healthcare-related issues without overcomplicating things. Hey, Greg, thanks so much for coming on. You've written and spoken extensively about pain, and I've really enjoyed some of your resources, particularly the pain guidebook that you put out for clinicians and patients. So I was wondering, what was your impetus for writing that pain guidebook, and what are some of the things that you think, whether it's clinicians or patients, should know about pain that aren't typically emphasized?
Thanks, Doug. Thanks for having me on. The impetus behind the pain guidebook was, these are things that I've been saying for a long time to my patients, and certainly things that other people, of course, have been saying and researching. Nothing was really original, but still, they were concepts about pain and injury and biomechanics that I would still say they're well proven and well researched, but they probably weren't the commonplace ideas that were out there amongst therapists or patients. So one of the ideas was, and some of them might be like a little challenging. Like if you say something to someone, that the pain that you have isn't because of that rotator cuff tear that you have, or it's because you have spurring at C5 and C6, and you can say that. We can say that to our patients, but that can be a little challenging or confronting to them because some other healthcare provider or maybe something that they know would conflict with that, and that's a hard message to deliver. And so the idea was I would want other people delivering the message and get as many people as saying this common message to change people's beliefs about it. So one of the thoughts was, like, say you're a practitioner wherever in Idaho, and you want to put across this new or updated meaning of pain and injury. You can say, go read this book here or this sheet, this one infographic by this guy, Greg Lehman over here, and read it, and then come back to me and we'll talk about it. We'll tell me what you think about it. So that way it's a little less threatening when someone else is delivering a message. I'm talking with Todd Hargrove tomorrow, and I used to always send people to Todd Hargrove's sites to talk about the same things that I was saying. So it was like more than one person saying the same idea. So that was the impetus. The other impetus was, especially in Canada, a lot of people don't have coverage for physio. They can't afford care. And I thought a lot of the things that we're doing, it can be delivered for free. So I was also hoping, to share information with patients for free. And I really like the idea of sharing information with other therapists for free as well. So that was the big impetus there.
No, I think it's great. Like I said, I've shared that resource extensively with some of the people that I work with, just because I think it's a good reminder to help reinforce not only good ideas, because a lot of the information that's perpetuated about pain is outdated. So on the one hand, you wrote this pain guidebook just to give people a more up-to-date resource to reflect what the current research and the current science is surrounding pain. But I think more importantly, there's sort of a downside if you articulate your message about pain incorrectly. So can you talk about what that downside is? It's not just about doing what's truthful and what's known at this point in time. There's also a downside to delivering the information improperly. So what's that downside as far as you can tell?
I mean, the big thing is we can set up our patients to fail, and we can scare them. And this is the problem, that like if you have a very biomedical approach, which still has a role, like say people think that pain is caused by, I'll go back to the rotator cuff example, by a rotator cuff tear or by the spurring, and you scare them away from activity, or you have a message that's a bit, motivates behavior change through fear. That might help a huge number of people, right? Don't do this again. This is the worst thing you can be doing. And that might empower them. And so they'll stop doing that, but they'll do other things and get better. But then there's like a subset of people where that fear of movement, or worries and fears and beliefs about their body, that actually contributes to disability. So I don't know if that really gets at what you're asking, but that's the idea by changing how people think about their pain. Or let me give you a better, an easier example. Like I talk a lot about posture, and people are set to think if you deviate from these neutral postures, and if you're slouched or leaning forward, or one hip is higher than the other, people will say, well, that's why I have pain. My muscles are tight and I'm weak. And then you kind of set people up to fail that way, because it's really hard to change posture. We slouch because it's efficient. A lot of us are weak and tight, and it's hard to change. And so if you tell people they have to change all these things, and we know it's really hard to change, you're setting them up to fail, because they'll be like, of course I have pain. I'm weak, I'm tight, I'm slouched forward. And I don't think those things are in general all that relevant. So does that make sense? Yeah, totally.
I mean, I think the idea is if you're telling somebody that their symptoms are a consequence of something that's not really changeable, and that, and we can't even necessarily prove that there's any kind of correlation between something like, more importantly, like static posture, where it's like if someone just stands there and they've got these deviations from what we think is optimal, even though optimal doesn't really exist, and we say, this is why you hurt. Well, like you said, we can't really change those things. So now it kind of perpetuates this vulnerability where, I mean, I've worked with plenty of people where I've had to almost talk them off the ledge because, excuse me, they've been to so many other medical providers who told them these things that aren't necessarily changeable, and then they feel like they can never get better. And the reality is, I mean, let's say somebody had, one shoulder that was lower than the other. They probably had that for a very long time, and then, all of a sudden, 20 years later or whatever, it started to hurt. So if there was this very linear relationship between something like posture and pain, they would have had that condition for a lot longer. So I think, like you said, it can make people feel more vulnerable than they really are, and then perpetuate a sense of hopelessness because you're saying that it's something that can't change, and that's the reason why they hurt. And it would be one thing if these things were true, but they're not even true. So if you're going to, I guess, advance a mistruth, you should at least be accurate. So I just want to emphasize there is a downside to these things, and I think that ties nicely into the fact that you've labeled yourself as a movement optimist, which I think is great because there's no ideal way to move, and you've made the point that there isn't a linear relationship between something like posture and pain. But I think what's interesting for people like us in the field of physio and even some medical providers is that we can't necessarily prove that anything is directly causative of pain. So we shouldn't advance some of these inaccurate statements about pain. But at the same time, and you've also said that even elite performers have deviations from what an expert might construe as optimal. So you've used like an Olympic champion in the marathon who maybe that person's knees wobble a little bit inwards when that person runs, and maybe that person has what a medical provider might say is flat feet, but that person's still winning the race and has no pain in a lot of cases and is looking behind all the other competitors that are trying to keep up with them. But I also think that it can be dangerous to say that just because someone is an anomaly from, especially at the elite level, as far as like technique goes and mechanics, that everyone should strive to necessarily to deviate from some of those norms. So even that winner in the Olympics in the marathon who might, wiggle at the knee a little bit and have a little bit of like overpronation, if we want to call it that person still looks a lot different than like the recreational runner with a massive overstride. So I guess my question is, how do we be movement optimists, but also...
Sorry, Doug, we're cutting out a bit there.
Okay. So I guess my question is, how do we be movement optimists? And also, people are coming to us for information, in some cases, about how to move. And even though there isn't an ideal way to move, movement is still a skill, and there's probably various degrees of good and bad. So you've talked about like hamstring stretching and doing sit-ups and how some of those things are vilified in our profession. And I don't think they should be vilified, but at the same time, just because they aren't damaging doesn't mean that they're good. And people are only doing them because someone like us told them that sit-ups and hamstring stretching are good. So what's that line we draw between performance, pain, and then how do we intervene as far as like the skill of moving versus just leaving it alone? Does that kind of make sense?
Yeah, I think when it comes to performance, biomechanics and technique are probably way more important than when it comes to pain, right? So we could advocate to tell someone to sit up straight and work on their thoracic posture, not necessarily to prevent pain, but so that they have that ability when they're older, or if they want to do back handsprings or backflips. So when it comes to function, the posture and the technique to me is just dynamic posture. It gets more important. So I like to listen to strength coaches and performance coaches there. Like there's, especially with higher force activities, like when you're putting as much force as you can into the ground, that the technique would be important, and then we let the biomechanist debate when it comes to that. When it comes to injuries, the technique probably is more important as well when it comes to high load activities. So I think that there's still a relevance there. Does that make sense?
That makes...
It's not pure movement nihilism.
Yeah. No, it makes total sense. And I guess, the question from there is, what is a physio's responsibility? Is the physio's responsibility to just help relieve symptoms? Or is it to go beyond that? And I guess that's more of like a professional identity question, because physios are always like labeling themselves the movement experts. So if you're going to call yourself that, presumably you would treat movement as a skill and not just strive to relieve symptoms. But at the same time, if you're viewing physio as a medical service, I don't know if performance, for example, should be covered by healthcare. So I don't know. What do you think the line is there, if there is a line, or what do you think is a pragmatic boundary that we can draw between that distinction?
So when it comes to training movement, again, that the research can help us lead us somewhere. When there are better ways to move, perhaps to prevent injury or to prepare people to prevent injury. So let me go back a step. So if you are going to be an expert in movement, then you should understand the sport or the activities of daily living that you're preparing people for. I don't think there's the best role for general movement screens. If you're going to be a movement expert, you have to know that sport. So I teach and do gymnastics and tumbling and trampoline. So I should know the demands of that, and I should create screens around that. So I think that movement preparation is one of the most important things that we can do. Same with running. We want to prepare people to tolerate all the loads on their body during the running. With gymnastics, you want to prepare someone to be able to tolerate all the stresses and strains that occur with gymnastics. So you need to create training programs that look at how the individual joints move and how the joints work together, and you slowly build up the resilience to every possible permutation of movement and stresses and strains that those joints and that system undergoes in the sport that you're trying to prepare them for. So that's the idea behind the optimism there. And then it's not just about performance, it's just about preparation, but I'm sure the performance would come along.
No, I think that's perfectly said. And so,
Sweet.
I guess where I'll go from there is, if you're a profession and you call yourself movement experts, you legitimately have to be that. And I think that in a lot of the physio curriculums, like what's taught in a therapeutic exercise class is not what you just talked about. It's not necessarily, the skill and the technique involved in various sporting activities. So if you're going to say that you're an expert, I guess it's a matter of make sure that you have the knowledge so that you're not false advertising, because to say that, because you can do clamshells that you're a movement expert, I think, the field has to do better if they want that to be its identity. And I don't know if that's what the identity should be, but it seems like the popular narrative now. So if that's going to be the narrative, there needs to be, I think, a little bit more emphasis on some of the things that you talked about, that you prepare for when you're working with, clients or athletes or patients, whatever you want to call them. So from there,
can I give another example? Sure. Just another example. So like, I would tell people if they're just going to lift their kids up, and if they're just going to lift stuff around their house, as a movement optimist, I don't really care too much about the position of their spine or how they do things. Yeah. I think you can lift things from the ground a number of different ways, and you'll be safe as long as you haven't, gone from lifting 2 pounds to lifting 100 pounds, right? Because you're not ready for it. So that's the movement optimist. It doesn't really matter the positions you get into. You're allowed to do it a number of different ways. Just slowly do it. But at the same time, I wouldn't feel comfortable teaching someone how to do the snatch or the clean and jerk, where I used to teach that, over 20 years ago, but I haven't really taught it in 20 years, and now it's not my area. So I wouldn't be able to get the most out of the performance for that patient. So that person would have to go, or patient would have to go to the movement specialist in the snatch and the clean and jerk or something like that. Does that make sense?
It makes sense. And it reminds me to make the point that what I was talking about before that explanation works both ways. So if you're a physio and you're working with a runner and you know nothing about running, well, then you're probably not the most qualified person, especially if it's somebody who wants to accumulate a lot of mileage and intensity and do so at a high level. But I think the reverse of that is also true, where if you have someone whose only goal is just to be able to pick his or her kids up and like throw them around in the pool, you don't need to teach them how to do power cleans either. So It's like, I think a lot of times, we impart like our biases on other people, and because we like to do certain things, whether it's like Olympic lifting or we have this sort of perception of what ideal movement is, we transfer that onto the people that we work with, when a lot of people just like don't really care. They just want to be able to do certain things and live their lives. And I think in those instances where there isn't a huge demand as far as like load intensity or even fatigue, we don't need to make things harder than they really are. And so I think that's the sweet spot, is just meeting people at their goals and at their story, and where a lot of that like higher end performance and movement expertise is required, then maybe we educate ourselves on that or refer out appropriately. But if it's someone who doesn't want it and just wants to, is just satisfied like living their daily lives and whatever they encounter in their surrounding environment, we don't need to go overboard. So I think your point's great. You've made the point both ways. I don't know. You have anything to add on that, or does that kind of make sense as well?
No, that's it. I'm with you.
Yeah. So we can go on and on about this, but you've essentially, a lot of your writing focuses on the fact that medical providers have extrapolated this trauma model of pain to non-traumatic pain. So we always assume there's this linear cause and effect between structural damage and pain. So like if you get into a car accident and break your femur, it's not a secret why your leg hurts. But a lot of the pain that people like us encounter is not related to any kind of obvious structural pathology, and yet the way that non-traumatic medical providers, ourselves included, are taught to diagnose typically revolves around this very reductionist structural pathoanatomical model where we say your shoulder hurts because you have bicep tendinopathy or possibly a labral tear, or your back hurts because of a disc. And I mean, you cited a lot of research showing that there's really no such thing as perfect anatomy, and that a lot of the things that we might, just because now we're so good at being able to detect things with our imaging, we're always going to find something that's quote unquote wrong, and that those findings don't always correlate with pain. So if we're talking purely about just like symptom reduction in these very obvious instances where the pain is not caused by something structural, how do you think that like medicine in general needs to change the way that they diagnose certain things. Because I feel like pain's become almost overly medicalized to the point that now we just like treat things for the sake of treating, when I feel like if you don't understand something, your default should be less treatment, not more. So we don't understand pain. We try to find a very linear cause and effect, and we say, you hurt because of the structural thing, which isn't always true. And that, I think, a lot of times perpetuates more care than people really need, and then makes them feel like they're more broken than they really are. So how do you think we need to change the way that we diagnose, or do we at all?
I think we need to expand our diagnoses there. So we don't always have to say that biceps tendinopathy is irrelevant, but view pain as more like a stew, right, rather than an apple. So if you just say it's a biceps tendinopathy, then you're viewing it as an apple. But really, sometimes that apple is just part of the whole stew. That there's all these other factors that go in to make up pain. And so if we're going to be treating people, we have to look at everything that can be sensitizing them, right? So I think there's kind of two points in there. I think you're kind of making 2 points in there. So our diagnosis and the areas that we address to help people in pain have to become broader, right? So we shouldn't expect to always find an anatomical structural contributor, or although that can be a factor. Or if we do find that factor, we say, well, what's mediating that? What's turning that biceps tendinosis into disability? Like, what else is going on in that person's life? And that's where it gets a little bit more difficult and harder. But that's the true biopsychosocial idea. Like that. That's why I talk about structural changes as like kindling for a fire. Right, that's the paper and the light wood and the dry stuff. But that in and of itself doesn't make a fire. You need some spark and accelerant and oxygen. So what we really treat, in my opinion, is the sparks and the accelerants and the oxygen. Like we don't really treat tendinosis. When we help someone with a tendinopathy, that tendinosis is still there, months or years later. We build up their resilience around that tendinosis so that they're functioning well, they have no pain. But then I think you're talking about something about pain there and how we might pathologize it. I think at a simple level, we shouldn't be telling people that they always have to be pain-free.
Yeah.
Right? That's really not fair, and again, or tenderness-free. So much in school where you're just poking people to find tender spots. And Christ, like everyone has those. And so we're like, oh my gosh, you're tender here. Yeah, that's because you're a human. We get tender and we're in pain sometimes. So fine line there.
Yeah, that's.
I went over my time.
No. I live in New York and I'm in my apartment now, and there's never any privacy. So that's probably some like delivery person trying to get into the building, and I usually just ignore it because it could be anybody. But you never have quiet even in your own home here.
Okay.
But he'll try it a couple more times, then it'll stop. This is real time podcasting here. But I think those are good points, because in reality, the only medical provider who can do anything about structure is a surgeon, at least in the short term. I mean, there's things that non-surgical providers can do over the long term to elicit certain structural adaptations. But in the amount of time that most people are going to a non-surgical provider for relief, no one's doing anything about structure. But there are a lot of political and financial incentives to pathologize pain and make it a medical condition all the time. So this is kind of more of a philosophical question. Do you think that medical providers should be the arbiter of who gets to work with people in pain outside of these obvious cases of trauma or structural pathology? Because your approach seems to focus more on like just creating adaptable human beings, desensitizing them over a period of time, and then building them back up. And one can make a case that medical providers aren't even the best or the most qualified people to do that, because they work with sick people. And if someone's not really sick or damaged, then why should the medical provider be the one who gets to determine who works with people in pain?
By medical provider, you mean medical doctors?
Well, no, I mean medical doctor, physio. I mean, the idea is even physios have branded pain where it's like, if someone's in pain, a personal trainer can't work with this person, or it has to be us, and like I don't think that's really that honest.
No, I completely disagree. I'm all for a big tent. It's the right person is the person, right? Like,
Yeah.
as long as, like, and we do this as physio, you rule out the really nasty stuff. You rule out a specific lesion that needs specific correcting. And then after that, it's fair game for a number of people to help out. And, you know, it's like a lot of roads can lead to Rome, right? So it's to use Jason Silvernail's idea. We should focus. It's a big tent. You know, a lot of people can help out here. So if someone has pain, then a personal trainer is absolutely welcome to help them out, or a psychologist, or a social worker, a physio, a chiro, massage, athletic therapist, osteopath, yogi. You know, all of these people have a role in there, you know, as long as the person's safe.
You made the point that there are a lot of providers, whether they're in the healthcare system or outside the healthcare system, that can help people in pain. And I think that where the political and the financial incentives lie is in being the first person or the initial triage point to work with somebody in pain. And I think sometimes falsely, even in physio, we feel as though we have to be master diagnosticians. So if someone has shoulder pain, we've got to figure out if it's a slap 1 or a slap 2. When I feel like in reality, it comes more down to pattern recognition and being able to just look at something and say, I've seen a lot of shoulders in my life, and this seems like there's something pathological that's going to impede any progress that I can make. And then at that point, you refer out to somebody who focuses on anatomy, which is generally an orthopedic surgeon. So I don't think that someone needs to be medically trained per se and have a doctorate to be able to be that initial triage point outside of cases of really severe, obvious, acute, traumatic pain. So what do you think should be sort of the educational background required for someone to be that initial triage point when working with someone in pain, if not a medical provider?
You know, I'm probably going to get this wrong, but Deo, you know, like 30 years ago, commented on this, and it was more about low back pain. But you got to be able to rule out the sinister red flags, or at least work with people that can. I think you have to rule out, you know, structural pathology that requires a specific fix, or at least that someone else should look at. And then it's almost like you're looking for the serious things. Yeah. And then you should be able to identify, you know, psychosocial and emotional variants that really need a specific thing. So, like say with depression, you can treat people with depression, but if they have depression scores over, like there's the patient health questionnaire where the depression scores are over a certain value, and they're not getting medical treatment, it's incumbent upon us to refer them to have their medical doctor look at that. So it's really just finding out the things where you need help, right? That's it, to speak in general, or someone else, like there's something specific that needs addressing here. Other than that, like then it's we can all be like safe with our patients. Yeah. And then the specific stuff, like, because we know that our specific diagnostic orthopedic tests aren't very good. They're not specific, and they haven't been for 20 years. Well, I guess never. And then what's interesting to me is so often you do all those specific tests and they don't even change what you do.
For sure. Yeah. I think that there's a difference between being able to identify those red flags and just knowing something is weird, and being able to exactly determine what the cause of those red flags is. And so unless you have like something like an MRI or blood work in your scope of practice, you're just speculating anyway. So it would be interesting to see if different professions could kind of sit down and have a conversation devoid of a lot of the politics and the fear-mongering, and figure out what are some reasonable boundaries for non-healthcare providers to work with people in pain. Because I think there's a downside to pathologizing everything and making, you know, anytime somebody perceives any pain, making it a medical condition and making medical providers only the gatekeepers to working with people in pain. So I think I think that ties into the next thing I want to talk about, which is, you know, we're both physios, so a lot of physio podcasts, it's all about like, how can, you know, we show everybody how different and unique physio is. And I don't know, I take the opposite stance, and I feel like a lot of times professions just try to market themselves and brand themselves as unique because it creates a niche in a shared market. But I think that a lot of times there's almost too much redundancy between a lot of these musculoskeletal providers, whether it's physio, chiro, physiatry, athletic training, massage therapy, acupuncture, and even personal training to a degree. So to forget, the fact that we're healthcare providers and have some skin in the game when it comes to branding each profession as unique. If you're wearing your sort of consumer of healthcare hat, do you think that having all this redundancy in the system overcomplicates things unnecessarily?
My answer is not straightforward. I think it does complicate things, but I don't think it's unnecessary. I don't think it's a bad thing. I think the redundancy should be occurring, because if we're all up to date and we're all reading literature and we're consistent with the science, we should be looking similar. That's the thing. If I'm a patient and other people who are patients, they should be looking for the best person, not the best profession. That to me is the issue. Because remember, I'm a chiropractor too, and I was a chiro first, and then I went back to training for physio school, and it didn't change anything that I did. There was no difference at all, because I felt like I was up to date before I went to school, and I was up to date after I graduated. So the redundancy across professions is hopefully a good sign of people, teaching and being involved in continuing education and keeping themselves up to date. But it does make it difficult for the consumer. So it's conflicting there.
Yeah, I think it's like you said, it's not a simple answer, because I don't necessarily like the idea of overly regulating these professions and somebody telling them, okay, you've all got to be the same and under one umbrella. But I think the key point that you made is that it's important that consumers of healthcare, I think it's great that they have choice, but it's also important that they recognize that if all these healthcare providers or even non-healthcare providers are staying up to date, they should come to mirror each other to a certain degree. And the distinctions between a lot of these professions, I know I shouldn't be saying this as a physio because I'm supposed to be advocating for my profession, are very arbitrary. And outside of the extreme cases, there really isn't a big difference between what a physiatrist does and what a physio does, and what a physio does and even a massage therapist or a personal trainer does. No. And, so I think there's two ways of looking at it. There's kind of what's your incentive as a healthcare provider, and what's your incentive as somebody who wants to maximize, choice for the patient and just create a better overall product and elicit positive outcomes for patients. And I think if you're focusing on the latter, then the distinctions between the professions really are arbitrary.
Yeah.
So we were talking a little bit offline about kind of, how you practice and I practice. And typically in our field here in the United States, physio, it's generally covered by insurance. And so typical person with, let's say, non-specific low back pain, so nothing traumatic, just an achy back, might get 3 days a week authorized by his or her insurance company for 6 to 8 weeks. And I feel like that can be problematic, because in some ways neither the consumer or the provider has a lot of skin in the game. The provider knows that he or she is getting, 18 to 24 visits covered no matter what. And the consumer feels like, well, I can just go in and get treated because my insurance company is paying for it. I'm not really paying a lot out of pocket. And at the same time, your approach is really more about developing adaptability and empowering the person to kind of do things on his or her own. And I feel like in some ways, knowing that you have 18 to 24 visits authorized might not be the best way to empower yourself. So do you think that from a systematic level, there's anything that that healthcare is doing, whether it's an insurance-based model or out of network, that might be problematic when it comes to the way that you look at pain or how you think we should be treating pain?
Yeah, again, I'm just focusing on the small percentage of people so for the vast majority of people, that's going to be fine for them. And in my opinion, that's a bit of over treatment. But a lot of them, they'll all do great. They'll be fine. They'll be out of pain. They won't have any disability. And it might increase your healthcare costs because it's probably unnecessary treatment. But economics aside, but then there's the small subset of people, who knows what it is, 5, 10, 15%, where when they come in and they hear, well, you're going to need, 12 weeks of care or 6 weeks of care 3 times a week, what does that say to them about their condition? Like, I must be pretty messed up if I need to come in here so often, and I need fixing. So, that's the issue. And then related to that, because I'm in Canada, so it's a bit different. Just from talking to my friends who are from the States, your system seems a touch rigid, where maybe they do need 12 visits, but not over 4 weeks. Yeah. It'd be much better if it could be spread over 8 months, because when you look at, like, after whiplash or some accidents, it's not true that most resolve in 6 weeks. There's a number of people where it can take 6 months, 8 months, and that's normal. And so maybe we're better off being like consultants and coaches, where someone can come back and see you in a month or 3 weeks, or they just dip in for a 15-minute Skype call, or I think we need to be more flexible, and it's not unreasonable to see people like 8 months down the line and for them to be still in a bit of pain, and maybe need some help and advice. There's nothing wrong with that. When you have a lawyer, they don't fix it. Whatever your problem is, always in 3 weeks. People have lawyers on retainers, right? It's we're a knowledge-based profession, and we can view ourselves that way, where we can do consultations slowly over time.
Yeah, no, that's a great point. I mean, like, in a vacuum, it's much easier to say, okay, like, what we do as musculoskeletal providers should be outcome driven, and not have these arbitrary timelines. You kind of hear about it in sports all the time, where it's like, okay, this guy just tore his ACL. Like, when is he going to be back? And it's like, he's going to be back when he's ready to be back. Like, to say 5 months, 8 months, like, it's totally arbitrary. And I get why health insurance companies do that, because it takes the subjectivity out of it. It's like, okay, low back pain is worth, 3 months and this many visits. It doesn't require any thinking, and you don't have to draw those boundaries. And those boundaries are, to a degree, subjective. But I think that when you make things non-outcome driven, it can just be problematic, and, like you said, kind of promote a lot of unnecessary treatment. Because what I really like about your approach and your guidebook is, it's like, education is a really key component to treating pain. And there are a lot of things now with, like, technology and online platforms, where if we're just teaching people to desensitize themselves and build themselves back up, I mean, to the extent that we can eliminate the need for ourselves and make ourselves more redundant, I think that's going to help promote empowerment, which is kind of at odds with our financial interests. But what do you think the role of education is here? And do you think there's like low-hanging fruit from an education standpoint that can minimize some of these unnecessary visits and just help to advance outcomes, so the patients, more the impetus is on the patient and not the provider?
I think it can be a start, but to me, I don't know how, when we look at the research, if education is that good in and of itself. To me, it has to lead to behavior change,
sure,
like to healthier behaviors. And now you're into more murky waters of what makes people change behaviors. So the education is the first start. Maybe you address a false belief that they have about pain, and that leads to someone doing something that might be healthy for them, like exercise, or starting to play with their kids, or cutting the grass, and all these things that might build self-efficacy. So education's a start, and then it has to go to, like, meaningful activities, to me. But again, all of it's still in a consultant role, where the person's still needed, but like the therapist is still needed, but it should be going to where the person's learning how to take care of all these things on their own. That's the idea.
Yeah, I think that's interesting, and I didn't really think of it that way, because if you just look at, like, the pure application of knowledge, like, you can create a YouTube video and an online program that says, okay, like, do these exercises on these days, and that'll help to desensitize you and build you back up. But like you said, it's more about behavior change, and maybe what makes that that personal interaction useful is that it's easier to modify your own behavior when there's someone there to motivate you a little bit. So we can't totally be replaced by some of these online, exercise and educational platforms. And I think it's like you said, it's complicated. It's this fine line between, all right, how do we not abuse our privileges and overtreat, but also recognize that people do need help and some nudging. And that's why I think, like you said, the consultant way of looking at it is really useful. It just involves a lot more subjectivity, which when you're trying to do things on a large scale like an insurance company does, it can be a lot more difficult. Does that kind of make sense?
Yeah, absolutely. It is a harder model to implement for them.
Yeah.
But I find it more rewarding. I had a patient this morning. He's a runner. He fell, and he's still running 100 miles per week. Wow. So he's doing okay.
Yeah.
But that's fun. We looked at that. There's no issues. But he also wanted a strength training program. So I gave him 5 exercises that were a plank series, front, side, back, and some squats and lunges and push-ups and pull-ups. Really general.
Yeah.
But then I also said, you don't need to do any of these.
Yeah.
If you have the principles here is you work your front, your back, your side, your upper body, your lower body, you can do that a number of different ways. So these are all good to do, just as long as you slowly progress over it. So we're trying to teach the fundamentals behind the exercise prescription, right? Not make it like it's a magical exercise. So
yeah,
I would say,
totally.
If the other exercise you want to do, we can talk about those, and you could probably do those instead of these. I said, you could see it's completely different, which would give you 5 or 7 completely different exercises, and they'd be just as good for you.
Yeah, it's like, I think that we matter, but just not as much as we think.
Yeah, maybe.
That's a great example.
My one point to young therapists is, and I always had this problem, I probably treated people less than I should have. I always say, don't beat yourself up. Like, not everyone has to get better immediately, and things will take time. And it's okay for people to come in a couple extra times, right? Because they're not going to be reliant on you. But I think there's sometimes a risk when we think I need to treat people less and less and less, where some people, they might not fully understand your message, and you don't even realize that at the time. So I always err on the side of 1 or 2 extra. It was always my problem as a therapist, because I think I went the other way and didn't do enough. And I just give people the permission. Don't beat yourself up. You're not unethical if they come in a couple more times. It's okay. You still have value.
Yeah, for sure. And then it's, if you take that empowerment thing to the extreme, patients could perceive that as you're trying to blow them off, and you don't want to treat them. So it's always a fine line with all this stuff.
Yeah, absolutely.
So you're a really busy guy. Like, where can people learn more about what you're up to? And I know you do quite a bit of educational things, and you've got resources for the general population and even for clinicians. So where can people learn more about that stuff?
Everything's at greglehman.ca or Facebook and Twitter. Twitter's just Greg Lehman too. I'm on Twitter a lot. And then that's all there. I'm doing the 2 courses now, the Reconciling Biomechanics with Pain Science, and then a running resiliency course. So that stuff's all there on the website.
Is the running course more for clinicians or for general public?
Clinicians, strength coaches, running coaches. I love when running coaches take the course.
Oh, cool.
Psychologists. I was in Amsterdam, and a psychologist took it. He was a sports psychologist. He was great. Running coaches are great. So
okay.
It's just taking the framework from the Reconciling Biomechanics course and applying it to running. And then I'm going to start doing more online training too. I'm just trying to figure out like a good platform for it that makes it both good for the clinician and gives them stuff they can use for their patients. That's my new excitement.
All right. Well, I'll be sure to put all those links in the notes of the podcast. Greg, thanks again so much for your time, and look forward to learning more from you in the future.